Hi, it's Brain Bites with Dr. B. Today I'm going to be talking about a little bit of some bipolar physiology. So, bipolar is the disorder that has some high highs and then episodes of very low lows. And in between that, there's euthymia. So, pretty stable, steady mood. So, it's very episodic and goes up and down with periods of sort of stability in the middle. So we don't really understand the whole physiology picture of bipolar disorder. So there are some thoughts that it has to do with some oxidative stress, that there is some immune component, that there are some mitochondrial diseases that may be causing problems. But we do know that dysregulation of ions is part of the problem. We have some genes that we've looked at. There's no single bipolar gene, but some of the genes that we find that kind of collect together with people that have bipolar disorder, they tend to affect all the things that surround these ion transports, the membrane potential, all this different stuff that's about exciting neurons. What we're really seeing, what a lot of the medications that we give are designed to do, is to affect the intracellular concentration of sodium inside these neurons. So when people are in a manic episode, the intracellular sodium increases higher than it's supposed to be. This makes the neuron very excitable. And an excitable neuron is able to send messages more easily. So we see people with increased energy, increased activities, pressured speech, less sleep. These neurons are ready to fire, ready to fire. They fire way more easily. And so that's when we see all that ramped up stuff with manic or hypomanic episodes. So in between, when somebody's euthymic or has their stable mood, we don't see these intracellular problems. When the neurons become overworked, the depolarization block happens, and those neurons can't signal anymore. That's when we tend to see a lot of the anhedonia, so slowed down, psychomotor slowing, the really low piece of the depression side of things. One of the things we don't really see with bipolar disorder is any problems with the dopamine or the serotonin systems. So even though we see symptoms that may be related to something that we would give an SSRI for or a selective serotonin reuptake inhibitor for, it doesn't necessarily actually have a problem in that area, which is why SSRIs shouldn't really be given to patients with bipolar disorder. The same thing with antipsychotics. Although antipsychotics do have an indirect mechanism to affect that intracellular sodium, they also affect dopamine in a big way. And it doesn't appear that that's something that we really need when treating bipolar disorder. So when we know there's a physiologic target that is causing part of the problem, it's great when we can give a medication to impact that target. That's the best case scenario. So when we know what the problem is, like in this case, intracellular sodium, we can address it with medications that we know will affect that. So the class of medications we use most often is the mood stabilizing medications. And these medications can directly affect the intracellular concentration of sodium. So when I'm talking about mood stabilizing medications, this is Depakote or valproic acid, lithium, which is Lithobid or Escalith, carbamazepine, which is Tegretol, oxcarbazepine, which is Trileptal. Even sometimes gabapentin or Neurontin is used, although that's lower down on the list. My very favorite one to prescribe is Lamictal or lamotrigine. I actually have it on my top 10 list for my medications. If you've had that, you know all about why I love lamotrigine. But sometimes these medications can be hard for patients to tolerate. Sometimes they have to be dosed at least 2 times a day. Many of them require lab monitoring, so we have narrow therapeutic windows. They have to be in a certain level to be effective, and if they have too much or too little, it can cause problems. And some of them have just terrible side effects. People can feel very sedated or dizzy or shaky. Some cause hair loss or a really dangerous rash. And they can cause some mental dulling or mental slowing. So these can be hard medications for people to tolerate, but they are gold standard, what anyone who has bipolar disorder should try to be stabilized on. And these medications have actually been shown to decrease the amount of episodes that somebody has. So it can help with relapse. Whereas the antipsychotic medications that are often prescribed to help with mood stabilizing, those don't typically prevent new episodes. So antipsychotics can be really helpful medications, especially when somebody is in an episode. These medications also have long-term medical risks to take into account. So there are longer-term issues with metabolic disease, so obesity, problems with cholesterol, triglycerides, diabetes, and also some cardiac conditions. So mood stabilizers may have their own set of side effects, but then with the antipsychotics, we're looking at side effects and long-term medical risks. And then, of course, there's the benzodiazepines like Ativan or lorazepam, very helpful for manic episodes to help calm people down, to slow their brain down. Those work through the GABA system, which also will end up indirectly affecting the intracellular sodium concentration. So if possible, it's best to have somebody on a mood stabilizer. If they can be on a mood stabilizer and an antipsychotic to help with some of those other symptoms, that's super helpful. Best to stay away from the SSRIs. This is a little bit of the physiology that we do understand about bipolar disorder, the targets for the medications, and this might be helpful information for some of your clients. So sometimes patients just getting a little bit of a better understanding of why they take a medication, what it's really doing, and how that actually helps can go a long way with compliance. So Dr. B with Brain Bites. Hopefully you learned a little bit about the pathophysiology of bipolar disorder.